Dr. May Fawzi. Dr. May is a professor of internal medicine in Kasr Al Aini, and she is a pioneer in inflammatory bowel disease and the bowel ultrasound. Her lecture will be in IOS as a novel technique in use.
Well, my lecture is called iOS, a Rising Star in IBD Workup. And this is because early in the early this decade, the main parameters for diagnosing IBD were endoscopy, CT, and MRI. And iOS did not feature in the guidelines at all. But due to lots and lots of research, iOS has become an important part in the IBD assessment. So according to the ECHO-SGAR guidelines, the most recent, iOS can be used for the initial assessment of patients suspected to have IBD, assess the extent of the disease and the presence of extraintestinal manifestations and complications, monitor therapeutic response, monitor remission, and allow patients to be de-escalated from treatment, detect disease activity and complications, detect post-operative recurrence, and it can be used as a prognostic tool for the assessment of disease activity. So what about initial assessment of Crohn's disease and ulcerative colitis? As you can see, iOS is as equal to MR and CT with positive high rates of sensitivity and specificity comparable to that, and highly comparable to endoscopy and histology. And even more so in colonic inflammation than in small bowel inflammation, and I will tell you why. I know that many of you will not be interested in iOS, so I got big pictures and I hope you can see them with me. Can you hear? Okay. It's very important for you to understand that the bowel is a very thin organ. Its wall is very thin. The maximum thickness of a normal bowel wall is 2 millimeters. And it's consisting of 5 layers. And what I want you to do is to understand these 5 layers and find pathology within them. Okay? So this is a normal bowel wall, and I'm measuring from inside to out. And as you can see, the bowel wall, from where the caliper is, I have put it on a white structure. This is a white line. And then there's a black line. And then a white line, a black line, and finally a white line. What are these? These are the interface of the luminal content, where there's air and there's food and there's gas. And then the black part is the mucosa. This is part muscle, part fluid, part cell. And then the white in the middle is the submucosa. It's white because it has less water. It contains vessels and collagen and cells. And then there's the muscularis propria, which is a muscle layer. This is black, more water, as you all know, you're radiologists. And lastly, the last white line is the serosa. When I measure, I do not include either the serosa or the luminal interface because these are very changeable things. I can have no content in the lumen. Am I going to put that in or out? The serosa might be hypertrophy due to any other reason. So I do not include it within the bowel wall thickness. So I would like to show you an abnormal bowel wall. And as you can see, I have measured an abnormal bowel wall that does not show the 5 layers. Where are my 5 layers? I have a white layer here, which I'm not going to include, and a white layer there, that is the serosa, I did not include. And in between, I cannot properly see the white layer in the middle. No submucosa, because inflammation leads to edema. Edema leads to hypoechogenicity. And as I can see here, this is a hypoechogenic lumen wall. Why am I measuring 2 measures? Because I wanted to show you this is called a skip lesion in Crohn's disease. Crohn's disease is not a disease of continuity like ulcerative colitis, it skips. And it's one of the diagnostic features. So here is a pathological segment that is not really very large, while here is a pathological segment that is much larger. The presence of skip lesions is diagnostic of Crohn's disease. And by ultrasound, I can see it very clearly. مش عارف هل ممكن أعمل كده؟ في pointer? It would be far, far easier. هو فين؟ شغال؟ طيب شكرا جزيلا. طيب اوكي. طيب زي ما انا بشوف wall thickness وبشوف wall stratification، هتكلم على حاجتين تانيين مهمين. بتكلم على morphology، يعني ازاي هفرق small bowel من colon. هفرق من presence of these. The presence of house tree. زي ما انتم عارفين التينيا كولاي بتخلي الكولن segmented. فيبان حاجة اسمها polycyclic. So I can see the house tree and I measure the wall thickness as you can see. But what about this colon? This is a colon too. Do I see any house tree? No. But I can see a wall that is thickened, hypoechogenic. I cannot see the submucosa, poor stratification, and there are color Doppler signals. So is that normal? No. Color Doppler signals in a very low flow situation would be only 0 to 2 spots. If I can see more than that, then I am in front of an inflamed bowel. As this patient here, this is a segment of the small bowel of a patient, and as you can see, there are many spots and segments leading to a diagnosis of grade 2 color Doppler flow. So even though the stratification is okay, the thickness is a little increased, and there is a lot of color Doppler flow. This is another patient with Crohn's disease, and as you can see, another pointer to the presence of inflammation is mesenteric fat hypertrophy. I have 2 lymph nodes. Both lymph nodes do not appear well. They are roundish instead of oval. They don't have a hilum, which is how we diagnose a normal lymph node by ultrasound, and they are surrounded by a lot of mesenteric fat hypertrophy. I don't know why this video is not working, but this was a video of the terminal ileum of a patient with Crohn's disease. Same patient. I don't know why it is not working. There you go. So there's lack of stratification, thickened wall, lots of mesenteric fat around the ileum as well, and around its pathological lymph nodes. So this was a patient not diagnosed with Crohn's disease, and now I have a diagnosis by IOS. Next, monitoring. I can use IOS to monitor for IBD, and the guidelines tell us, yes, you can, within 12 weeks, check for response to treatment in ulcerative colitis, and you do not need an MRI there, or you can monitor with MRI if it is Crohn's disease or endoscopy. So why did they choose that? In the STRIDES-2 trial consensus statement, IOS was recognized for its revolutionizing disease monitoring due to its ability to assess for disease activity throughout the entire bowel, its repeatability, as well as its ability to assess for transmural healing. طب ايه اللي انا parameters اللي هستعملها اقول ان في healing? The sonographic response is either a reduction in bowel wall thickness by more than 25%, or by more than 2 millimeters, or a reduction of 1 millimeter and 1 point of the color Doppler signal. So if I find a response of only 1 color Doppler signal reduction, this is not considered response. And this is a chart showing how to assess within 12 weeks response to therapy. In ulcerative colitis, I need clinical biomarkers or clinical patient-reported outcomes or biomarkers plus IOS or endoscopy, and in Crohn's disease, biomarkers and clinical assessment with cross-sectional MRE or IOS. On par. So this is one of my patients who had taken biologics, and his CDAI was less than 150, meaning clinical remission. The patient said, I feel fine. But when I performed the ultrasound, I told him, unfortunately, you are not fine, and we will have to escalate therapy. This is another patient with Crohn's disease, and this is his terminal ileum, his sigmoid colon, and he was on steroids and azathioprine for 12 weeks. And as you can see, poor response to therapy. So what if the patient is in remission? Do I stop monitoring the patient? No. If the patient is in complete remission by ultrasound, endoscopy, and patient-reported outcomes, I should follow him up every 6 months with fecal cal. This is the most important thing to monitor with, more than CRP, and intestinal ultrasound. Endoscopy will only be needed if the patient has something more or there is a disparity between the two assessment tools. So what about complications? Intestinal ultrasound can be used with a high degree of specificity and sensitivity equivalent to CTE and MRE in the detection of small bowel strictures. Unfortunately, it has a weak point. This weak point is the proximal jejunal loops. I cannot see them well by intestinal ultrasound, as well as the rectum. So how can we overcome this limitation? Small intestinal contrast ultrasound, CCUS, is a very interesting tool where I ask the patient to drink 350 and up to 800 millimeters of PEG, which is polyethylene glycol. And after the patient drinks them, it's a non-absorbable, non-metabolized type of substance. It remains in the bowel, distends the wall, allows me to check for the presence of this thickened valvulae conniventus. It can show me the bowel wall configuration very well, so I can say, yes, here the stratification is fine, when here I could not have said that about it without this contrast. Moreover, okay. This is one of our young patients who presented with constipation, abdominal pain, and weight loss. Okay. And if you note, this is his terminal ileum right there. It's stenotic, the lumen is empty, there is increased vascularity everywhere, and look at this, pre-stenotic dilatation. Seen very well, I can tell this patient has a problem. And there is, of course, excess mesenteric fat hypertrophy. Detection of fibrosis in all diagnostic methods is very poor. So I cannot verily say by MR or CT or in ultrasound that this patient has an inflammatory stricture or a fibrotic stricture. Most strictures have both, but which is predominant? There are still studies that tell us that shear wave and strain elastography on the ultrasound can be promising tools to detect fibrosis. As, for example, this thickened bowel loop, which has an excess of color Doppler flow, and when I put my shear wave here, I can check that there is excess blue, meaning excess fibrosis, excess stiffness. What about the presence of abscesses and phlegmons? A phlegmon is an inflammatory mass, and an abscess is a collection that does not have any vascularity inside. It has developed a wall, and now it's an abscess. As for example, and fistula, of course. This is an inflamed bowel loop, and this is another one with a fistula in between. A fistula is a hypoechogenic structure with gas in the middle. It sometimes does not show, like, for example, in this fistula, where this is an inflamed bowel loop, and this is its fistula. This is one of my patients. He's from, no, not him. I'll show you another one. As you can see, this is a markedly inflamed bowel loop, and there's very poor stratification. There's a suggestion of here, a tract right there. This is not bowel, this is a fistula. and there is leaking from the bowel wall into the surrounding fat. The surrounding fat is trying to collect and hold on to the inflamed loop. Okay? Very characteristic, in need of therapy. What about contrast-enhanced ultrasound? We just heard about contrast-enhanced ultrasound of the liver, but contrast-enhanced ultrasound is a very good tool to detect the presence of inflammation, as it's an intravenous microbubble that is injected, and it goes straight to my target region of interest. I can see the region of interest lighting up due to the invasion of the microbubbles through the dilated microcirculation. It can detect and quantify inflammation, and it can differentiate between a hypoechogenic mass, whether it's a phlegm or it's an abscess. A phlegm would light up completely, but an abscess would not. Unfortunately for us, we do not have contrast-enhanced ultrasound in Egypt, as the government will not allow the presence of the bubbles. مش عارفة ليه. يعني what is wrong with the microbubbles? Hazard. طيب. كمان ال iOS is a very good tool for the assessment of post-operative remission or post-operative recurrence, and the recommendations depict that we can monitor in 12 weeks post-operatively for recurrence of the disease. طيب تاني مشكلة قلناها كانت إيه؟ Our second problem in intestinal ultrasound is the rectum. It's a very deep organ, and I cannot detect the rectum properly and its pathology, the presence of abscesses, perianal fistulae, by transabdominal iOS, and therefore transperineal ultrasound, which has been here for a very long time, used by the gynecologists and surgeons, but now we can use it in IBD to detect perianal fistulae or active proctitis, as well as pouchitis. It's placed on the perineum, and it gives a very good image of the inner and internal and external anal sphincters, as well as the rectum. And here, as you can see, all these studies and more would say that there's good correlation, a valuable tool, excellent depiction, concordance with everything, shows very good signs of being a very efficient tool in the detection of rectal IBD. Every cross-sectional imaging modality has a problem of being validated. To validate anything, you have to talk in the same language worldwide. This means we have to have scores, okay? So in iOS, we also have scores that are related to IBD. The most important and the most validated internally and externally are the Milan ultrasound criteria. It's the best for ulcerative, and the IBUS SAS score for Crohn's disease. These scores improve reporting. They increase accuracy and reliability. And these are how the scores are done. Our measurements are put into an algorithm or into an equation, and then from there we get a numerical value that tells us, is the patient in activity or not. Lastly, I would like to tell you that artificial intelligence has invaded everything, including iOS. So as you can see, some companies have already introduced artificial intelligence into their machines, and this is one of these machines where I can put a region of interest, and the machine will tell me the bowel wall thickness, stratification, measure for fibrosis, for vascularity, and assess transmural healing. Very interesting. So my take-home message is iOS has multiple advantages. Its recent innovations and new techniques have overcome many of its limitations. iOS complements clinical assessment, guides decision-making, improves patient monitoring and follow-up of remission. And thank you very much.
Thank you, Dr. Mai, for the excellent presentation.